My name is Zvonimir Krejzer. I'm an interventional cardiologist at Texas Heart Institute and Baylor St. Luke's Medical Center in Houston, Texas. I'm also a clinical professor of cardiology at Baylor College of Medicine and the program director for peripheral vascular interventions at Texas Heart Institute. I'm also immediate past president of the International Society of Endovascular Specialists. It's a special pleasure to be invited as a faculty to the Icarus meeting. I would like to thank for this invitation to the program directors of Icarus, Dr. Skowronski and also Dr. Oskins for the opportunity for the International Society of Endovascular Specialists to be a part of this very prestigious educational event.
I'm Vinko Vidjak from Zagreb, Croatia.
The city of Zagreb, it's a capital of Croatia. It's a culture, scientific, economic, political and administrative center of the Republic of Croatia, and it's a home of Croatian parliament, government and president. Zagreb is a safe city whose doors are always open. The first written record of Zagreb came from 11th century, precisely 1094 year. In 1991, the Croatian parliament proclaimed independence of Croatia as a sovereign state.
Croatia is a domestic country, a country of the Thai. It's named Kravata. It's a domestic country of the pen. While the guy was Penkala, he was from Zagreb. And also, it's our national color, red and white. I'm proud of Zagreb because it's a green city. It's appropriate size of the city. It's not too big, it's not too small. I like the Zagreb.
Hello. Good afternoon in Poland and good morning, early morning here in the United States. So the Iliac session should be of interest because it covers a lot of territory and issues. I hope everybody hears me well.
Yes, perfectly. Yes, Zvonko, you can start your presentation.
Okay, thank you very much. The topic of this challenging case presentation is related to both sessions, to the aortic session and iliac session. And this is a pretty common occurrence in my practice and my experience, how to do EVAR with challenging aortic anatomy and also complex iliac anatomy. Can we go to the next slide? Yeah, thank you. Those are my disclosures. As you see, I do a variety of different stent graft devices for EVARs. Next, please. So this patient is an 83-year-old female that was treated at our institution 5 or 6 years ago. She presented with a large abdominal aortic aneurysm that measured 5.5 centimeters in diameter, as you can see, and also had a CTO of the right external iliac artery. In addition to that, she had a relatively short infrarenal neck. At the renals, it measured 22 millimeters, and it was funnel-shaped, and it measured about 10 millimeters at the distal site. It was 10 millimeters in length. Now, in a distal aortic neck, we have a circumferential calcification, and the internal diameter was 8 millimeters. In addition to that, as you can see, there was extensive calcification of both common iliac arteries, and then a CTO of the right external iliac artery. So the challenge was how to treat this very complex anatomy. She also had many comorbid conditions: coronary artery disease, previous infarct. She was a chronic smoker, COPD. She had a single kidney. She had a nephrectomy done previously for malignancy, and also she had chronic renal failure. So I would like to ask maybe Gregor or anybody, how would you approach this particular complex scenario? Would you consider surgery even with those comorbid conditions? Would you consider endovascular approach, and how would you treat it? Now, obviously there are many choices. If anybody wants to comment, you're more than welcome to do it. Any comments, suggestions?
Jan, do you have any suggestions?
This is Jan Skowronski. Hi, Zvonimir.
Yeah, I hear you. Go ahead, Jan.
Excellent. You don't need to see me. So I think this is actually fairly favorable, difficult, but more or less favorable case for endovascular approach. I think having strong enough support catheters and let's say glide wire advantage and perhaps a trailblazer catheter, I think you have very good chance of crossing chronic total occlusion and then performing aorta bifem stent graft. I think we would take that case. Thank you.
Okay. So, yeah, another challenge was how to treat very narrow distal aorta. And of course, that's another issue. But let me, next slide, let me see the next slide, if you don't mind. So we decided, as Jan suggested, to try the endovascular approach. And we always use in this type of scenarios or any kind of scenarios where we gain femoral artery access using ultrasound, as shown here on the left side, and micropuncture technique, as you can see here. And then we visualize this side in place, particularly because we do almost exclusively all of those procedures with percutaneous approach and local anesthesia. And this is how it was done in this particular patient. Next slide. So the intervention, as I mentioned, was performed with bilateral access in the common femoral artery. Fortunately enough, they were pretty clean, as you can see, and free of calcification. Next. And we recanalized the right external iliac occlusion, as Jan suggested, with a super stiff hydrophilic wire. It was not difficult to do it. And this is the cheapest and the simplest way to do it. We always approach it first with a hydrophilic wire when we have a CTO. In more advanced and longer occlusions that are more complex, we will use one of the CTO devices, and there are several available. But in this particular case, it was not needed. And then we placed 6 French sheets in both common femoral arteries and used a 6x4 balloon to dilate extensive disease in both external and common iliac arteries to be able to proceed with the PVAR procedure or percutaneous approach. We then proceeded with pre-close. This is not correct. The pre-close was done only in the left common femoral artery with a ProStar XL, and that's where the main body of the stent graft will be delivered through. The right side was pre-closed with one ProGlide, 6 French ProGlide, because this particular device that we will use requires only 7 or 8 French sheet for the contralateral approach. Next, please. Next, please. So we used as you can see, endologic stent graft that is unique in a way because it can treat very challenging infrarenal neck anatomy or distal anatomy, even below 1 centimeter in diameter. And the reason that this can be done is because the iliac limbs or bifurcated component is only in the iliac segment, not in the aorta, like we would see with some other stent grafts where we have bifurcated stent graft and iliac limbs originate very high in the aorta. And that would obviously compromise the flow to the iliac segments and cause the occlusion. As we can see here, the completion angiogram showed excellent result with good placement of the stent graft and no evidence of endoleak and no evidence of compression of the iliac limbs. So another advantage of this stent graft is that it consists of endoskeleton. So the stent material is on the inside and PTFE is on the outside. and that does not cause any internal irregularities. So that was for our patient, and in our view, one of the best options available. Of course, there are many other scenarios as it has been presented in the previous presentations, but we thought that that would work the best in our patient. Next one, please. Next slide. So this case obviously illustrates treatment, the challenges that we encounter in patients with complex abdominal aortic aneurysm, and also in the presence of CTO of the iliacs and severe circumferential calcification of the distal abdominal aorta that we encountered in this particular patient. Next. So due to this patient's comorbid conditions, as we mentioned, and she had numerous, this patient was not a good surgical candidate, obviously. Next. So that's why we believe that percutaneous approach and local anesthesia in a PVAR technique offer this patient lower risk than surgery, particularly in a scenario like in this patient with a complex EVAR. And unibody stent graft that was used in this patient, in our opinion, was the best choice for this complex anatomy. So I think this case is open for discussion, and I would like to hear from other panelists. I don't know how many of them are, but we should have a bingo there, and Jerzy, and Radoslav, and of course Jan. So
to Professor Krajcer, which is, may I can say, homeland Croatia, where I'm from. Congratulations for excellent case, and I didn't have a similar case. And first of all, congratulations because of a lot of obstacles which you solve with this grafts. I haven't experienced with that kind of the grafts, and my first impression will be maybe to use in my conditions in Croatia unilateral prosthesis. And I want to ask you, in these circumstances, with a lot of obstacles, and of course to escape from the surgery, in some case, will you use the multi-layer stents to cover that kind of the aneurysma of infrarenal portion of aorta?
yeah, I think those are all very pertinent questions, comments. And we do not have a multi-layer stent here in the United States. That's number one. I think that certainly is an option. And aorta iliac also is an option with then fem-fem bypass. So that certainly is a possibility. But again, this would have to be done under general anesthesia, and the patient, well, it could be done with epidural spinal anesthesia, but this patient had a lot of comorbid conditions, as I said, COPD, coronary artery disease, and all of those things. But certainly that's an option there for those that maybe don't have this particular stent graft available.
Thank you.
Jan?
Absolutely, Zvonko. One great case. So after you prompt me on stage and you embarrassed me several years ago in front of probably 500 people, I started doing stent grafts. And I found AFX device from Endologics very nice. But I have to tell you that in my clinical practice, I would say most cases that I actually use stent grafts for, it's actually a combination of aortoiliac occlusive disease and an aneurysm. Like doing a pure aneurysm without aortoiliac occlusive disease is relatively rare for me. Maybe it's just Alabama, or perhaps this is the fact that I'm a cardiologist as you are, and they really probably don't that much want us here. And I know you have a lot of experience with PVAR, with essentially everything you do, or most of the things you do, are percutaneous. So that's just a comment. Thank you. Great case.
Yeah, I agree with you that this is a rare type of a case. Most of them that we treat are classical aneurysm without distal neck degree. CTOs are pretty straightforward. I would say from previous discussion, I always try to cross with endovascular approach any CTOs. And so that's my approach. Of course, I'm an endovascular specialist. I don't call myself cardiologist. I call myself endovascular specialist. And the reason for it is that just to answer the previous discussion and these turf battle issues is, if you're going to do anything, whether you're doing TVAR, TAVR, EVAR, or whatever, you have to become an expert. And you have to be able to address most of the complexities and issues, and you have to do it on a regular basis. So you have to gain expertise in whatever you do, and I'm sure you agree with that, and everybody else agrees. So, for those of us that are not vascular surgeons or surgeons, you always need a backup surgically. So I agree with Gregor from that point of view that most of those procedures belong in the field of vascular surgery, unless you are superbly trained and you have tremendous experience and you do it on regular basis. So that's my comment. And Gregor, you might want to take over, because I would also like to ask you, Gregor, if you can co-chair this session, because I will have to leave relatively soon because I have some other obligations.
Dr. Kreitzer, thank you very much for your wonderful speech. And so see you somewhere on air or in US. Thank you very much. Okay, thank you. We want to ask the next speaker, Professor Pietura, and he will present the subject iliac vein stenting for chronic venous insufficiency. And the question is, do you use IVUS or not?
Good afternoon. My name is Radosław Pietura. I'm interventional radiologist from Lublin in Poland. I'm a big fan of new technology, but not for fun, but for daily routine practice. It's our proud 7 Tesla magnetic resonance for human use, first in East Europe. I strongly believe that new technology can lead to better treatment and improvement of long-term results, especially when we can use 2 or 3 modalities to better understand anatomy and pathology of lesions. I try to avoid narrow, limited look at the patient. Thank you very much.
Good morning and good afternoon. I would like to share my screen. Is visible or not?
Not now, but yes.
Okay, we have.
Yes.
Okay. Once again, good morning and good afternoon. My name is Radosław Pietura. I'm interventional radiologist. It's completely new in this conference. I'm from Poland, from Lublin, and my talk is going to iliac vein stenting for chronic venous insufficiency with or without IVUS. When we are, I try to, okay. We are talking about chronic insufficiency, we think about reflux and obstruction. There are 2 main reasons for vein obstruction. Post-thrombotic syndrome, which is well known, is not complete recanalization, and non-thrombotic iliac vein lesions, which is more complicated because almost 60% people in the world has huge compression without any symptoms. Moreover, there is no precise definition of venous stenosis. It could be 60%. It's completely different than artery. Moreover, there is no objective hemodynamic test for significant outflow obstruction, and diameter of vein is changing during breathing or changing position. So we need really precise imaging. 10-20 years ago, we based our diagnosis on venography, and we thought that non-thrombotic iliac vein lesions are a rare cause of chronic venous disease. Now, when we use IVUS, we found that incidence of non-thrombotic iliac veins lesions are very high in symptomatic chronic venous disease patients. So probably non-thrombotic iliac veins are silent permissive lesions. What does it mean? It means that this lesion is silent until some additional injury trigger symptoms. It's similar to foramen ovale, which is completely silent until a patient has stroke. So maybe we can use IVUS and think that we know everything, but we have to also look at the severity of symptoms. Because when we have a young patient with middle symptoms, it's enough to just change lifestyle modification. When we have patients with varicose veins and minimal edema, sometimes we need only superficial surgical procedure. When we have older patient with bilateral edema and no sign of venous disease, we have to find some other reasons for symptoms. And we have very huge obesity, and which lead to intra-abdominal high pressure. We have to try to fight with obesity when put stents. But when we have patients with moderate or severe symptoms which lead to changing quality of life, we have to implant stents. But in many cases, we have to delay until childbearing is complete. Why? Because uterus can compress our stents, and because low molecular weight heparin may increase risk of bleeding. What about imaging before procedure? Mostly is based on ultrasound, but we use also MR venography, which is very promising, and you can see, but technically demanded. I really believe that MR venography will be a gold standard in the future. What about imaging during procedure? For many years we use venography, but to be honest, venography provides information only about and collaterals. And venography is completely inaccurate for complete diagnosis and procedural guidance. So we have to use IVUS because we can assess not only degree of stenosis, but also level on confluence and profunda, extent of disease and stent landing zone. And we can assess also final result. And we can measure maximal area stenosis in compression portion of vein, below compression, or also stent after implantation. I would like to present our case report. It's a young male with left leg edema. You can see on phlebography, you can see compression. Also in IVUS, we can assess huge compression over left common iliac vein. And we decided to put a venous stent 20 millimeter in diameter. We put 18 millimeter in diameter. We put with overlay guidance. We also put guideway from left to right iliac just to assess where is confluence, and bilateral phlebography looks quite good. We are really happy, but at the end we put IVUS probe into the stent, and we found compression in IVUS and stents and stent, which cover only part our lesion. You can see also in ultrasound with probe. You can see the same picture. So we have to put additional stent. You can see IVUS control after last stent, and you can see vena cava inferior and stent cover the whole lesion without any compression. From literature, we know also that IVUS is very useful. It's a very nice paper from Miriam and Raju from 2019. They analyzed more than 150 limbs and found that venography failed to identify almost 20% of lesion. And stenosis in IVUS is close to 70%, while in venography, 50%. It's a huge difference. Also, we can find iliocaval confluence, which more higher in IVUS than with phlebography. Distal landing zone location is lower with IVUS than with phlebography, and this difference sometimes is really huge. We use also IVUS in different cases. You can see young lady with pelvic congestion syndrome. When we find also a huge compression, we put stents and coils just to treat all lesions. Sometimes we do procedure with the novo stents without IVUS, but only when the reason for occlusion is foreign body. You can see catheter and occlusion on both iliacs and part of common vena cava inferior. We put 3 stents, and we believe that it's enough. But you can see huge collaterals. We do another phlebography a little bit high, and we found total occlusion. So we put additional stent, and then in the end there's no collaterals and nice flow. And we did this procedure without IVUS because it was useless. As a conclusion, I would like to underline that maybe venography is very accessible and cheap, but only with IVUS you can precisely identify and quantify the disease, as well as location of optimal landing zone. And all these factors are very crucial for a long-term result. Thank you very much.
Przepraszam za taniec, nie spodziewałem się, że to tak będzie wyglądało.
Thank you very much for your presentation. I have one question, Radek. How do you treat the young lady after the iliac thrombosis, but she is still young and she wants to be pregnant in the future? Do you think that we should stent this kind of patient or wait after the last pregnancy?
It depends on the severity of symptoms. If a patient is very symptomatic, you have to put stent. But if it's borderline, we suggest just to treat only symptoms and wait until last pregnancy.
Professor Widiak, do you have any question about the venous stenting?
I completely agree with Radoslav, because it's a new field in the last 5 to 10 years which opened for all of us. I'm an interventional radiologist, so I'm a lot of involved in vein disease, and always I ask myself, where is the healthy portion of the veins? So usually we think that the 50% and more of the thrombus, it's not good, but usually we try to move to the tailoring approach to the patient. So intravascular ultrasound, it's excellent because give the information about the wall, about the web. Especially it's very important today because we move with the stents distally, as we have to go distally from the inguinal ligament. So the understanding of the changing in the common femoral vein, it's very important for all of us. Because of that, I think the intravascular ultrasound is very important. First of all, because if we want to performing some ballooning, we have to understand what will be with trabecula of the wall. And today we have on the market couple of stents. So I think if we use the combination closed and open cell stent, ultrasound, intravascular, it's very important for myself. I don't know you, Radoslav, or you, Jan, what you think about that?
This is Jan Skowronski, Birmingham, Alabama. So we have certain experience. In just 2 words, we 90% of the time we stent. And over the last several years, we've seen more and more Turner syndrome. We just got Vichy stent proved about 6 months ago in the US, and we are happy with it. And in terms of IVUS, we 100% agree. I would say 100% IVUS for a venous case. Thank you.
Okay, thank you very much. So right now we are come back to the arteries, and may I ask Dr. Stawiszewski to tell the technique for aortoiliac occlusive disease. Piotr, the floor is yours.
Hello, my name is Piotr. I'm vascular surgeon from Przemyśl, from far eastern Poland, and welcome to Icarus Digital Symposium.
Good afternoon for Poland and good morning from America. And thanks very much for inviting me for this sessions. And we started.
Piotr,
yeah,
you can start.
This is mine. So we can run. Yeah, aortoiliac occlusive disease, infrarenal aorta and iliac arteries. types. Types 1, disease localized to the distal abdominal aorta and common iliac arteries. Type 2, widespread aortic and iliac disease. And type 3, multi-level disease along with infrainguinal disease. Task 2, type C lesions. Next slide. Okay, task type D lesions. Next, please. And treatment, open repair and endovascular procedures. Next. Task C and D lesions, the subgroup of lesions involving the aortic bifurcation, represent a challenging situation. The traditional endovascular approach in these cases is the kissing stents technique, which is associated with the excellent techniques, success rate, and low medical and surgical complication rate, and satisfactory long-term primary patency rates, 81% at 24 months and 69% after 5 years. Next. And kissing stents technique, next. And the vascular approach to the aortic reconstruction is the CERAB technique, which is in aortoiliac disease, has been well described for the treatment of the complex aortoiliac disease involving this portion of the infrainner aorta. Next, please. CERAB technique consists of the deployment of balloon expandable covered stents above the aortic bifurcation, proximally adapted to the aortic wall with balloon creating. 2 iliac balloons expandable covered stents are then planted to the distal conic segment and simultaneously inflated, making the tight connection with the aortic cuff. Next. Next. Objective of the endovascular treatment is high technical and clinical success, low complication, high patency on the short and long term. Type of the obstructive lesions, stenosis, chronic occlusions, acute chronic thrombosis, and methods of the treatment, PTA, bare metal stents, and covered stents, and thrombectomy and thrombolysis. Please, next. Recanalisation, in most of cases, from the antegrade from above, or retrograde, or rendezvous technique. Next. Risk factors for aortoiliac PTA stents is occlusion length, number of stents places, small diameter of artery, young age, because a small artery, critical link, ischemia, poor distal runoff, external iliac artery, female gender, a small artery too, and comorbidities. Next. And this is the trial about the compression of the covered and barred expandable stents for the treatment of aortoiliac occlusive disease. Next. And device comparisons, and the best primary patency in 1 year is VBX 96 and 7%. Next. And in my practice and last year, I used and I preferred the VBX balloon expandable endoprothesis. Next. Next. Artery stenosis, next please. And case 1, this is Leriche syndrome. Please run the angio. Okay, patient 6 years old, critical limb ischemia, myocardial infarction 3 months ago, coronary artery disease and occlusion of aorta and the iliac arteries, CT scans. Cardiac output about 30%. Next, please. And run the video. And next, please. Access left brachial artery and the path common femoral artery, recanalization from above to the femoral artery, first predilatation aorta and the iliac artery. CERAB technique, implantation to aorta VBX 1159, and implantation to the iliac VBX 879 and eventus 8757, and additionally live stent 858. Next, please. This is run first angio. Next. And this is first angio after recanalization. Next. And this is after predilatation. Next, please. And this is implantation VBX 1159. Please run angio. That's okay. And one more angio. Yeah, after implantation, the VBX 1159 to the aorta. Next, please. And implantation to the iliac, right VBX 879 and Eventus 857. And please angio after implantation. Okay, and the next, please. Okay, and the next. And case 2, Leriche syndrome, male, 54 years old, critical ischemia, claudication 50 meters, hypertension, coronary artery disease, ischemic stroke, former smoker, stenosis of the aorta and the iliac arteries. And angio, please. Yeah. Next, please. Next, please. Procedure access is common femoral artery, and it was retrograde recanalization. And please angio. First, we implant VBX 1179 to the aorta, and 2 VBX on the right, 859, and VBX 879 to the iliac, and the angio, please. And K3 is the focal in the critical causes of years angioification, 100 meters, tension. And the next slide, please.
Please wrap up in 1 minute.
Next slide, please. And this is angio, run angio. That's okay. And the next slide, please.
1 minute remaining.
Access from the right femoral and recanalization, angio, please. Run angio. We implanted VBX 1159 to the near of the aorta, and we made angioplasty by low pressure balloon. And the next angio, please. This is right position of VBX, and the next angio, please. Run angio. That's okay. And next slide, please. Next slide, please. And can you run more slides to forward? More slides. More slides. Okay, it was a patient with the POW of the thoracic, and we have critical stenosis of both iliac artery. We put VBX 879, and we inflated over 16 atmosphere, and ran sheath 22 French through the VBX and put this thoracic stent graft to the thoracic aorta. And the next slide, please. And one more next slide. And the Leriche syndrome and the occlusion of femoral artery, we can run more slides forward. Okay, this is from case from the Monday, and I have on my computer the slides. We can go forward. We made endarterectomy of both groins, of both femoral arteries, and put the VBX stent graft to the aorta and to VBX 859 and 879 to the iliac and the final angio. Next, please. Extensive iliac artery occlusion is task C and D. It's technical success 86 to 100%, clinical improvement 83 to 100%, length of the hospitalization 1 to 4.8 days, 5 years patency, it's 60 to 86%, and secondary patency 80 to 98%. Mortality 0 to 67%. Morbidity 3 to 45%. Most common complication is access site hematoma, distal embolization, arterial dissection, pseudoaneurysms, and iliac artery or aortic rupture. Next slide.
So, Dr. Stabyszewski, this is Jan Skowronski. I don't know if you can hear me. We will need to conclude.
This four cases is the young people with coronary artery disease, with the very ill heart. So it's not good for the open procedure. So this, in my practice, in my opinion, in these cases, it's endovascular first. And I think it's the first conclusion, and the second conclusion is in aortoiliac occlusion disease is in our practice, covered stent is the first choice, and is now on the market is very nice. So cover stent, this is VBX. We can open the VBS from the 8 to 12 to 14 millimeters, and from the 11 to 16 millimeters. So it's very nice to put to the aorta. So thank you very much. And
thank
sorry
you so much.
problem.
And I think
okay, friends,
we
probably we have to move on to the next presentation by Professor Głowiński, because he will talk about the same problems, but his approach is a little bit different. So Jurek, please.
I'm Jerzy Głowiński from Białystok, the capital of Podlasie. Białystok is a beautiful city, green city with many green areas, more than 500 years old. Białystok is a cultural melting pot with many nations living here for centuries. Neighborhood of Belarus, Russia and Lithuania had an impact of the city. We have 3 universities here, and the beautiful historical building of our medical university you can see behind me.
Good morning and good afternoon. I hope you see me. I will share with you my experience with CERAB technique, and it will be as kind of supplement to Piotr's presentation. Indications are obvious aortoiliac occlusive disease, but sometimes the technique can be used for also for other indications like aneurysm. I will show you how to do it. Stent grafts are better because they prevent thromboembolization, and they have ability to fix complications like perforation and some other. But please remember that some devices are dedicated for peripheral vessels only, and diameter more than 60 millimeters cannot be obtained. We use mostly balloon expandable stents, and there are several available on the market, but there are plenty of differences between them, like steel used, so they are from stainless steel or cobalt chromium. Cobalt chromium have stents have better radial force. EPTFE can be encapsulated, or sometimes struts are opened, and you must look, be careful. Sheath size and maximum diameter from 16 up to 24 or even 30 millimeters after post-dilatation. My choice, Advanta V12, until it disappeared from the market in 2016. Aorta, Advanta large diameter, I think. I mean, Then I switch to B graft, and sometimes the technique can be used for also some for other indications. Okay, and I had a case with VBX. Procedure is standard. Recanalisation from below. Both groins are prepared. Sometimes we have to use brachial artery to do it from above. Percutaneous access in most cases, 9 or 11 French sheath. Sometimes we have to do open procedure, and tromp enterectomy at the same time is needed. We have to remember about 15 millimeter rule. So 15 millimeter above bifurcation and 15 millimeter of sealing zone to both stent grafts. And I will show you some standard procedures like here. Bilateral iliac stenosis, stent grafts implanted into this disease, and final angio, aortic stenosis and dilatation, and final angio after procedure. Control CT at 12 months, you can see nice result, first case, and the other case with occluded iliacs. Sometimes we have to prepare brachial access. So right groin was unsuccessful, left the same. We did dissection, so we switched to brachial access. We were successful this time. You can see sheath here. And then we have a good support and we could attack the left side. We were successful and we get through the occlusion. After standard CERAB, there was stenosis left, so we add another stent, and final angio was satisfactory and showed a good result. My second advice is always identify outflow problems, both groins and also external iliacs, and you can see that sometimes there's a real problem with external iliac arteries. Additional stents and additional balloons are needed to do it nicely and to have good result. Common femoral artery cannot be always prepared by percutaneous access, so sometimes when diseased, we have to do it by open technique, like here. My next advice is to do the shortest lumbar, to do the shortest aortic coverage because of lumbar arteries. There were some cases described of spinal cord ischemia after this procedure. So if we don't need to do it on the long segment, we do it rather on short segment. Another artery to remember is inferior mesenteric artery, especially if it is important, like here. And sometimes, it is possible to save this artery, like it was done in this case. Sometimes we can use a kind of chimney CERAB, like here, 69-year-old female, no pulse on both femoral arteries, walking distance quite short, and angio-CT revealed a coral reef aorta here, and we decided to do it with a balloon expandable stent graft. First angio, when you can see right renal artery protected by balloon, and final angio after 2, B graft inserted and post-dilated into aorta. Another indication is pseudoaneurysm, like here. There was a pseudoaneurysm 3 years post aortobifemoral graft. Patient was completely unfit for general anesthesia due to his cardiac comorbidities, and we decided to use a CERAB technique, and you can see quite nice result, but please remember, don't do it too often. we can do it only in life-saving indication rescue procedure where there is no another option, because it will be not possible to exclude aortic aneurysm with balloon stent graft permanently. Aneurysm is a kind of progressing disease. There are two other options for aortoiliac occlusive disease. First is seen here, balloon expandable stents, and another aortic stent graft designed for EVAR can be also used for occlusive disease. And especially this device is interesting because of this publication. So typical CERAB was seen not to be ideal solution because of this mismatch between aorta and stent grafts, iliac stent grafts, and this volume of static flow like here, which prompts to thrombose and to provoke intimal hyperplasia. So we can use stent grafts, ideal stent grafts, like was seen at the first presentation of Professor Zaitsev previously. So keynotes to remember: percutaneous access always. Sometimes it's needed. We need brachial access. We have to prepare a full range of catheters, guide wires to pass through the occlusion. We have to prepare a full range of balloons and stents for external iliacs. And when common femoral arteries are occluded or stenotic, we have to do it at the same time. Thank you very much, and greetings from my city.
Please, do you have any question about the last two presentations?
Unmute. Okay, Jerzy, this is Jan Skowronski, Birmingham, Alabama. Welcome back. And Grzegorz and Jarek, go ahead.
Okay, so but no, the question is, do you have any questions to the speakers? Concerning two last presentations.
This is Jan. If I can just offer a comment.
Yes,
it
please.
Seems like all our speakers have been very successful in treating aortoiliac disease, and I was very impressed with cases by Dr. Stabyszewski a lot, and Dr. Głowinski and others. One thing I can say is that in majority of cases, we actually use radial access to treat iliac disease. And the reason I cannot really use brachial access is that I'm not a surgeon. I don't have the ability to do any cut downs and then suture it up or stitch it up. So I use radial access, but there is a lot of new devices that actually allow you to treat not only iliac disease, but also SFA. And over the last year or two, Terumo came with R2P line of products that allows you to treat from radial basically to mid and distal SFA. And I would say 90% of patients with iliac disease go home the same day. So same-day discharge has been really, really adopted where I am. Thank you.
Jan, I have a question. How long is this sheet? Because sometimes it's difficult, you know, to go from the radial artery to the, of course, to the end of the aorta to iliac. It's probably okay. But if you want to go a little bit further, more proximal, it could be difficult. How do you deal with that?
It is actually not difficult at all, and I think you should try. So the length of the sheets we have is 125 centimeters, and the length of the shaft of the balloon it's over 150. And we start seeing devices with 180 shaft. So you can really reach down to the popliteal artery, and we do more and more of those cases. And I think it also, I'm absolutely delighted that the next session is chaired by Craig Walker, because Craig has probably the most experience in the world in treating peripheral arterial disease from radial access. Thank you. Back to you.